Good morning, everyone. My name is Anand Parekh, and I'm the Chief Medical Advisor here at the Bipartisan Policy Center. I want to welcome all of you to our event today entitled 988, Answering the Call, a discussion on the state of mental health in America and the role that the new number for the National Suicide Prevention Lifeline 988 will have for the growing number of Americans in need. As many of you know, America is facing a mental health crisis, which has only been compounded by the COVID-19 pandemic. Studies suggest that even prior to the pandemic, between 20 and 25% of Americans struggled with mental illness. These numbers, according to the Kaiser Family Foundation, surged to about 40% in the wake of the pandemic. These troubling rates of mental illness impacting all Americans present us with a unique and historic opportunity to implement the new dialing code 988 and to help connect more Americans in need to the appropriate behavioral health crisis services. For years, federal policymakers have been hard at work trying to get a handle on ensuring that Americans urgently in need of behavioral health supports could access services. In particular, the Substance Abuse and Mental Health Service Administration, SAMHSA, launched the original 10-digit National Suicide Prevention Lifeline number in 2005. This was followed by the creation of the 988 number, which began to take shape in 2018. The official launch date of 988 is now just a month away, although we know the number is working in many places already, and is coinciding with a wave of recent data indicating that more and more Americans are experiencing mental distress and in need of behavioral health crisis services. That is why BPC is excited to release our latest report today on ways to bring the 988 program to life, aiming to address several of the biggest policy challenges, including number one, establishing federal standards for a coordinated and equitable state and local crisis response beyond 988 call centers to include mobile crisis response teams and crisis stabilization. Number two, expanding, diversifying, and training a crisis-specific workforce. And number three, determining federal supports and guidance to make the most of existing resources for across the continuum of care. Today's report is part of BPC's broader behavioral health portfolio, which also includes recommendations guiding the federal government's role in behavioral health and primary care integration and optimizing federal spending for the opioid crisis. Before we get to more specifics of the report we're releasing today, I'd like to thank a few very important folks. First and foremost, thank you to Helmsley Charitable Trust for allowing us to undertake this important work at such an opportune time. We'd also like to thank our consultant on this project, Mary Giliberti, Chief Public Policy Officer at Mental Health America, for working with us this past year to bring this report together. Finally, a big thank you to our many expert contributors who have given us their time over the past year. I'd also like to thank BPC Senior Vice President Bill Hoagland, Marilyn Serafini, who directs the Health Policy Project here at BPC, our Senior Policy Analysts, Michelle Gilbert, Julia Harris, and Kendall Strong, as well as BPC staff Brady Newell and Tara Hartnett, all for making this project a reality. This morning, we had planned to start our event off with remarks from the Secretary of Health and Human Services, Secretary Javier Becerra. Unfortunately, the Secretary could not be with us today as he is recovering from COVID-19. We wish him well, and we applaud his leadership and dedication to addressing Americans' behavioral health challenges. In his place, we're very honored to have the HHS Deputy Secretary, Andrea Palm, with us. As Deputy Secretary, Andrea is the Chief Operating Officer, responsible for overseeing the day-to-day operations of the department. Previously, she served as Secretary Designee of the Department of Health Services in Wisconsin, and previous to that, held a number of leadership positions at HHS during the Obama and Biden administration, and I had the good fortune of working with her at that time. Andrea, welcome. It's nice to see you again, and I'll now turn it over to you for some opening remarks.
Great to see you as well, and I really appreciate the opportunity to be with you today, and I will absolutely convey to the Secretary your well wishes and certainly appreciate that. I also, if I might, want to acknowledge Dr. Adams and Dr. Everett, also current and or former members of the HHS family who have been leaders on this topic and really do appreciate their leadership and continued work and participation today. I also do want to thank the Bipartisan Policy Center for bringing us here together this morning. As you noted, Anand, this is a very opportune moment to release this report and to be lifting up these issues as we look to transition the 988 number. I really am privileged to be here on behalf of Secretary Becerra and grateful for his confidence as he has tapped me to lead our behavioral health work here at the department with our colleagues across the enterprise, as this really does touch on a wide variety of our operating and staff divisions and our programmatic work across the department. Behavioral health crises really are among the most consequential health issues that we face as a nation today, and anyone, regardless of age or ability, race, or gender, can experience a behavioral health challenge such as depression, suicidal thoughts, substance abuse, and post-traumatic stress disorder. Nationally, more than half of parents express concern over their children's mental health and well-being. And we estimate that in this country, 1 in 5 older adults experience a mental illness at some point. And although they represent about 12% of the population, they account for 18% of all suicides. According to the Centers for Disease Control and Prevention, suicide is the leading cause of death in the United States, resulting in about 1 death every 11 minutes. And the number of people who think about or attempt suicide is even higher. And provisional data from CDC's National Center for Health Statistics indicate an estimated 15% increase in drug overdose deaths in the United States between 2020 and 2021. Unfortunately, this behavioral health crisis, as you noted, is only been exacerbated by COVID-19. The pandemic has added stress, anxiety, isolation, grief, and worry in what have already been very challenging times. I certainly saw this firsthand during my time in Wisconsin, and the struggles that Wisconsinites faced, made worse by the pandemic, are the struggles that were shared by every American from coast to coast, from urban to rural communities, just across the board. And so supporting the behavioral health of the American people is an issue that demands our continued focus and effort. Mental health and substance use disorders are public health problems, but they're preventable, and everyone has a role to play to save lives and support healthy and resilient individuals, families, and communities. And President Biden certainly recognizes this, and all of us here at HHS recognize it as well. It's really why back in March, during the President's State of the Union, he made behavioral health a core pillar of his unity agenda. And with the President's call to action, our goal here at HHS is to advance transformative behavioral health solutions and really integrate behavioral health into the healthcare system. We at HHS have been on the road connecting with communities across this country to meet with teens, with families, with healthcare providers, with a variety of stakeholders to ensure that Americans in need of behavioral health services can more easily connect to the care that they deserve. In the last 12 months, we've invested billions of dollars to address the behavioral health crisis in our country. We've created a new mobile crisis unit benefit in Medicaid, and we've awarded more than $6 billion to our community health centers nationwide. And this really just scratches the surface of the work that's underway here at HHS. Now, as all of you know, next month is the transition from the National Suicide Prevention Lifeline to this easy to remember 3-digit code. Transition to 988 on July 16th. It's really an important step forward and offers an unprecedented opportunity to strengthen and transform crisis care in this country. 988 will be available 24/7 via call, chat, and text to all people experiencing a behavioral health crisis. Transformation of this scale is never easy, and we must all work together because the federal government can't do this alone. HHS is prepared to support all of our states, which is why we have awarded nearly $105 million to states and territories to strengthen and expand crisis call center services and have taken an all-hands-on-deck approach to urge partnership with HHS for a smooth 988 transition. Earlier this year, SAMHSA created the first ever nationwide website connecting interested individuals to 988 job opportunities around the nation. And later this summer, we will host a webinar for undergraduate institutions and undergraduate associations to discuss the 988 resources that are available for students and the workforce opportunities that the Lifeline centers have for students and recent graduates. It's true that we have a lot of work ahead of us, but I'm deeply proud of our progress and our commitment to addressing the behavioral health challenges that our communities face. But again, we cannot do this work alone, and that is why we're really grateful to have partners such as all of you. I thank you for sharing your report and for your recommendations that are not just for us here at HHS, but for the country as a whole. And now I ask you to join us really in redoubling our efforts. As Anand noted, we're a month out from transition, which will certainly last beyond that July 16th date. And we need to work together to make sure that this transition is successful. We certainly expect there to be challenges. Again, transformation of this scope is not easy, but with strengthened collaboration and partnership, we're confident we can respond to those in need of behavioral health services. So thank you again for having us here today, for the work that you are doing. And we certainly here at HHS look forward to continuing those efforts together. And I'll turn it back to you.
Thanks, Andrea, for those remarks and for joining us today. Thanks to the department's important work on behavioral health and on its preparations for the 988 launch. And I know BPC would like to continue to serve as a resource to the department and as helpful as we can moving forward. So thank you. At this time, we'll move to our first panel discussion. I'm very pleased to welcome Drs. Jerome Adams and Anita Everett. Dr. Adams is a presidential fellow and executive director of Purdue University's Equity Initiatives and distinguished professor of practice. He was the 20th U.S. Surgeon General under President Trump, the former state health commissioner for the state of Indiana, and is a practicing anesthesiologist. He remains a leading voice on the state of health in the U.S. and on mental and behavioral health specifically. Dr. Everett is the director of the Center for Mental Health Services at SAMHSA, leading the nation's federal efforts to improve mental health service systems, and as part of that role is overseeing the implementation of 988. She previously served as the section chief at the Johns Hopkins Bayview Community and General Psychiatry and is on the faculty of Johns Hopkins School of Medicine and the Bloomberg School of Public Health. She has spent over 2 decades devoted to behavioral health policy, serving in prior roles within SAMHSA and in the state of Virginia. Jerome and Anita, nice to see you. Thank you both for joining us today for this important event and for the conversation that we're about to have. And Jerome, if I may, I'd like to start with you. If you can just share with our viewers and tell us about what you've seen both during and after your time as Surgeon General about the state of mental health in America today, and how more specifically, and I think Deputy Secretary Palm alluded to this, what you've witnessed with respect to the COVID-19 pandemic impacting individuals' mental health.
Well, thanks for having me here today, and I'm really excited about the launch of 988 because in direct answer to your question, the state of mental health right now in America is not good. We know the pandemic, as the Deputy Secretary talked about, has really put a magnifying glass on some problems that existed and amplified them. We've seen rates of mental illness spike 25 to 41% from 2020 to 2021 among adults. And my successor, Dr. Murthy, has helped highlight the fact that this is even higher among adolescents. So bad that in December of 2021, he issued a national advisory about the youth mental health crisis. This is due in part to the pandemic, high rates of social isolation, people out of school, job loss, economic stability, and other pandemic-related factors. But it's important to note that this was a trend that we saw long before the pandemic. From 2010 to 2019, deaths by suicide increased from 38,000 to 47,000. We saw that amongst youth, we had a 57% increase from 2007 to 2018 in suicide amongst youth aged 10 to 24 years of age. We're all very familiar with the opioid crisis, and we hit a record in 2019 pre-pandemic. We blew that record away during the pandemic. So this has been a continuation of a trend, and that's why the National Suicide Prevention Lifeline is going to be a valuable tool, an essential tool, and will become even more accessible to Americans as it transitions into 988, which will be much easier for people to remember, utilize, and access.
Thank you. Anita, and transitioning to you, building off of what Jerome just mentioned, this Lifeline currently exists for about 2 million Americans in need every year. I understand some SAMHSA projections estimate that the number will double once 988 goes officially live and more people becoming familiar and comfortable with dialing in. Can you give our viewers today a little bit more of a background on the original version of the Lifeline and how 988 is going to change how Americans interact with the Lifeline? How does 988 differ from the current 10-digit number?
Sure. Yeah. I mean, Lifeline, as was mentioned, has been in existence for a number of years, and over time, it's gradually increased its utilization. And so, the most recent year, it had about 12 million calls to it, and so we anticipate that to increase as we go forward with that. It was started out more narrowly focused on suicide, based on the idea that most people who get into the space of thinking about suicide have some degree of uncertainty or ambivalence when they're in that space of thinking about it. And a call many times can avert the actual attempt. Since then, it's grown, and we've seen a lot of systems, and we've grown the notion that a call alone, while it can be very effective in averting some suicide attempts and also other crises that are related, we know that other resources are useful. What I'd love to do is tell a very short story that I think paints a really good picture of how we envision the Lifeline working when it's fully built out, which it is in many communities, and we're increasingly seeing that. So many of us are sports parents, and we know what happens when you have a child who has an injury on a sports field. We know the play stops in the game. Parents are on the sidelines. They make a decision about whether 911 is called. An ambulance may or may not come depending on the need of the child. And everyone who's on the sidelines in the community knows what could happen to the child. They might go to the emergency room. They may or may not see a specialist in the emergency room, but we kind of have an idea of what's going to happen. Same family, the same age child, an adolescent male child. The mother hears him crying in his room one day while he's trying to do school from home. Goes up into his room. On his bed, there's a noose that's fashioned out of one of the father's neckties. What does that mother do? What options does she have for urgent care for her son? In our worldview, this mother calls a friend who's heard about 988. She calls 988. They talk with an individual on 988, and a decision is made about the urgency of the situation. Is it the kind of situation that could go to a clinic that afternoon that has a same-day access style clinic, which is another sort of program that we're working really hard to ramp up our accessibility? Is a decision made that he's fine. He's had some hiccup with a friend, and that's going to get better. So that the process is thought through. The child gets mad and he says it's not fine. An hour later, there's hysteric crying coming from the room, and so the decision is made that somebody needs to come. So they call back 988, and this 988 is connected to a mobile crisis unit, which comes in a plain car. It's not a policeman with a flashing light on it, neither is it an ambulance that all the neighbors are going to see that may or may not have the right trained response. There's an intervention, a trained individual comes to work with the child and the family in that setting. If it's still determined after that point that the child needs additional care or might even need hospitalization, that the remedy isn't working, then there might be a need for a place to go. And that might be an emergency department, which are available, of course, nationally. It might also be a crisis receiving unit, which has a higher ratio of skilled professionals that can help manage and stabilize the situation and stabilize the person and have the person home with a tight discharge or tight discharge plan and or seek inpatient care if that's what turns out to be necessary. We know from experience in various states that systems that have these three elements built out, someone to talk to, a place, someone to respond, and a place to go, really reduce avoidable hospitalizations and the stress that's associated with hospitalization, and can get folks effectively to the right level of care and address situations earlier on. And so we see this this 988 development, which will be transforming in a month from now, as an important first step. And our vision is that this be very much akin to the way 988 is now. So 911, the way 911 is now, so 988 will be for expediting behavioral health response, so we can get people to the right level of care and the right intervention earlier. Timeliness is very important.
That's a really helpful example, and it helps us make it real. And Jerome, I don't know if you want to build on that. The actual National Suicide Hotline Designation Act, which officially created 988, was signed into law by President Trump when you were Surgeon General. And so your sense of, and you started to talk about this, but your sense of how 988 can be impactful to Americans.
Well, again, I want to highlight a point that you brought up, and there's a strong bipartisan support for this program, spanning two different administrations from two different parties. This is a problem that is nonpartisan. Everyone agrees that we need to make it easier for people to be able to access services. And 988 will be a crucial access point for behavioral health services for the increasing number, unfortunately, of Americans in need. Important to understand that anyone, regardless of their income, can call to receive free support. And as Dr. Everett mentioned, 988 in many cases is going to be better situated to respond with the appropriate tools for behavioral health crises compared to existing emergency response services such as EMS or law enforcement that often come when people call 911. And I want to highlight that this doesn't mean that 911 structures are ill-equipped for these types of challenges writ large, but it does mean that this new 988 system gives more space to those best suited to address these specific needs, which helps everyone.
That's great. Thank you. Anita, I want to turn to a question I think on a lot of people's minds. We know that many states and local governments are still significantly unprepared in many cases for the launch of 988. In fact, I think there was a recent RAND healthcare report on preparedness of the US for 988 and seemed to confirm this notion. This is true despite the federal government, including Congress. Jerome just mentioned the several recent administrations all focused here, providing robust program funding for the crisis continuing. I think Congress recently increased appropriations for the National Suicide Prevention Lifeline by $77 million. President Biden has requested an increase in behavioral health supports in his FY 2023 budget. Congress is working to attempt to expand and diversify the workforce, integrate primary and behavioral health. There's a lot going on, all bipartisan efforts that BBC continues to support. But tell us how the federal government plans to help states more prepare for 988. I know a lot has been done, but what more can be done? Because it sounds from the front lines that that there are a lot of places that are unprepared. Now you said this is going to take time, but maybe if you can talk a little bit more about what the federal government is doing.
Sure, that is the case, and that's, as Deputy Secretary Palm mentioned, we know that there are challenges with something of this magnitude, but we also have the firm belief that this is going to make a big difference for a lot of people's lives in increasing access, and really is, part of the unity agenda, increasing the capacity as well as the access of the system, or connecting people to care. So there are a number of different ways that we're looking at that. The first of those, as you mentioned, is to strengthen the existing National Suicide Prevention Lifeline, which started out as a very modest program many years ago, and is really has significant support, and that is to build up the infrastructure, or the skeleton, so to speak, of the system. And these are the call centers nationally, so that they're better equipped to be responsive as we have increased volume to the calls. So strengthening the National Suicide Prevention Lifeline is one of the ways. We've created also a number of funding opportunities. So as Deputy Secretary Palm mentioned, there are several grant series that we've created. We also have, through the bipartisan efforts of Congress, added a set aside to our block grant, which means that every state has some opportunity through that, and will in the foreseeable, indefinitely have ongoing money to build up crisis systems across their state. And we are encouraging them to think about that statewide. We know that will be, some places will be earlier implementers than others, and it won't be uniformly available, of course, not a month from now, but we're really encouraging that to states to catalyze that. There are a number of other sort of third categories, products and convenings that we've had to sort of look at specialized components of this. An example of this is a policy academy that we're conducting over the next month that will bring together local 911 and 988 operators to knit together some of the response, so that we know if that mother, say for instance, with the suicidal son, were to call 911 in a community that's well connected, the 911 operator may connect the person to 988 directly. So there's good operational communication between those. We've created products and support for specialized communities that we know have high risks of suicide, including the American Indian, Alaska Native populations and the LGBTQ community. And so there are a number of different products, many of which we've created ourselves, and many of which we have created through a partnership with the National Association of State Mental Health Program Directors, which are the state commissioners throughout America. So there are many different resources that we're creating. Some are in development right now, but we're all with the urgency to get things out as soon as we can, because we want to support the proper development of this system and maturity as best we can.
That's great, very helpful. And actually it touches on, I think we have time for one final question, which is very important. So I want both of you to respond to it. Anita, you just started too. We know equity in access to care is a problem across the health system. We know this is especially true for access to mental and behavioral health care. It impacts individuals of different demographics, different geographic areas, minority populations, those in rural areas, for instance. So can both of you speak to some of the challenges in equity when it comes to mental health care, and most importantly, how you hope 988 might help to address these equity challenges?
Well, I'll let Dr. Everett finish, but quickly, I want to highlight that there are both demographic and geographic disparities in rates of both mental illness and mental health issues and access to care. You've heard many mention. The African-American community has seen a much higher increase in opioid overdose rates. We know that rural communities see higher increases in suicide rates. I was just in Alaska a few days ago, and we highlighted the impact on the Alaska Native and American Indian communities. And we know that 988 alone is not going to fix this problem, but it provides opportunities for federal, state, and local entities to work together and to bring states to the same baseline for the national behavioral health crisis response. That's how we address inequities. And I'm glad to see one of the recommendations in the BPC's report is for a national scorecard to ensure consistent performance across the country. This will allow standardization of services across the continuum of care and help us tackle some of these disparities by allowing state-to-state comparisons and allow us to pinpoint which states need more support and how we can best support them. I mentioned the rural community. They face unique challenges. Several studies coming out later suggesting that rural communities suffer higher rates of mental illness, and again, as I mentioned, higher rates of suicide. And they certainly suffer more acutely from provider shortages. So I just want to highlight as I close that the BPC's report addresses workforce shortages, especially disparities amongst providers in rural communities, with recommendations for innovative recruitment partnerships that will serve rural America. But we really have the impact of all of you watching help spread the word about 988 so it's utilized, and help us build out the capacity so that when someone actually calls 988 in your community, they are able to be quickly and promptly referred to high quality resources that exist.
Great.
That's great.
Yeah. Thank you, Dr. Adams. Well, what I'll just add quickly is that we're very aware of the longstanding situation of certain specific communities, particularly African-American communities, being reluctant to call 911 because of what might happen on the other end. And we're working very hard to do what we can to assure that the reputation of 988 is not tangled up in that, and that the call will result in help and is used, is equally accessible across our entire population. And this includes children as well. We as a special population, we also want to assure that crisis services are available to children or families who might be calling on behalf of a child, because one of the other concerning statistics is the rising rate of young children thinking about attempting suicide. And so we're very interested in that. But equity with regards to access is very important. Cornerstone of the way we're developing 988.
Thank you for highlighting that, Dr. Everett. And I know we're closing, but I hope the next panel will cover this too. If we have any reporters on it, I want people to hear this. There are communities of color that are scared to call 911. So not only is 911 ill-equipped to deal with mental health services in some instances, or not the best people to call in some instances, but many communities are afraid to call 911. And so 988, if launched properly, can be a real lifeline to many communities out there that currently don't have one.
Yeah, it's such an important point. Thank you for raising that. Thank you for this discussion. This was just terrific, Dr. Everett, Dr. Adams, for educating us today on where things stand. Thank you for your leadership, and we really appreciate you joining us.
Thank you.
I'd now like to hand things over to BPC's Kendall Strong for our next panel, which will speak a bit more to the specifics of our report. Kendall?
Thank you, Anand, and thank you, Dr. Adams and Dr. Everett, for taking the time to be with us today. As Anand said, I am Kendall Strong, and I'm a senior policy analyst here with BPC's health team. Again, we want to thank Helmsley Charitable Trust for their support on this project, Mary Giliberti for serving as our consultant, and the dozens of other experts, state officials, and stakeholders who helped inform and craft this report, some of whom are here today, as well as the entire BPC team. Very briefly, our new report, Answering the Call, outlines, as was mentioned, some recommendations for ensuring that the new 988 number serves as an access point for Americans in need in crisis services. And you can access the report at our website, bipartisanpolicy.org. Our report, in a nutshell, tackles the following three broad policy areas. The first is ensuring federal support, collaboration, and coordination to and with state and local governments for an equitable crisis response implementation. Two, supporting, expanding, and diversifying the crisis response workforce. And three, sustainably financing the infrastructure for and coverage of services provided along the crisis continuum. We have three experts here with us now for a panel discussion. Before we jump in, I just want to remind the audience that they are welcome to engage with us and to ask questions of our panelists on Twitter with the hashtag BPC Live. With all of that said, I'm going to go ahead and introduce our panelists now. First, we have Wendy Tygreen. She is the director of the Office of Medicaid Coordination and Health System Innovation with the state of Georgia's Department of Behavioral Health and Developmental Disabilities. Under Wendy's guidance, the department runs one of the nation's most comprehensive statewide tech-enabled behavioral health crisis care networks. Next, we have Karis Myrick. Karis is co-director of S2I, the Mental Health Strategic Impact Initiative. In addition to serving as president of the board of directors at the National Alliance on Mental Illness, Karis also served as president and CEO of Project Return Peer Support Network, director of the Office of Consumer Affairs at SAMHSA, and chief of peer and allied health professions at the County of Los Angeles' Department of Mental Health. And finally, we have Mary Giliberti. Mary is the Chief Public Policy Officer at Mental Health America. Much like Wendy and Karis, she is truly an innovator and forward thinker in the crisis space. She has contributed widely to efforts to promote federal policies which aim to foster prevention, early intervention, integration, and recovery into behavioral health care, and again, was a major contributor to our report, and we really thank her for that. Prior to joining Mental Health America, Mary was also the Chief Executive Officer at the National Alliance on Mental Illness. Good to have you all here today. To jump in, thank you. To jump in, Mary, we'll start with you. As Anand and Drs. Adams and Everett just spoke to, we know that access to behavioral health care services is not equitable either geographically or demographically across the US. We know this to be true as well when we look specifically at crisis continuums. We've got states such as Georgia, which have fully operational continuums in place, and other states which are struggling to staff call centers, build out their crisis continuums. Can you give us your sense of the bigger picture as you currently see it of 988 readiness across the country? Are we ready?
No? Can I go ahead? Okay, sorry. As I was saying, I want to recognize the work of SAMHSA, which has really done some hard work in expanding our Lifeline and the local call centers, but we know there's still more to do. Those resources need more, and they also need sustainable funding. So when you look to the states, which is another source of that funding and also implementation, as we mentioned, Georgia, we know that only about roughly 22 states, when I last looked, had statutes around 988 that were substantive, not just planning statutes. So we have over half the states that still have a lot more work to do. And then when you look at particular populations, I know it was mentioned for youth, and what we're seeing is while there are gaps across the continuum for adults as well, it's particularly acute for children. And we're hoping that SAMHSA will soon release guidelines specific to behavioral health crisis services for children, because children are not little adults. They need their own service system. And then the other issue that was just addressed was messaging. And Dr. Adams did a great job talking about the concerns of the Black community around calling a number. We really need to see there are a variety of concerns for populations, whether that be immigration status or police involvement. And we need to have research and then message testing with those communities. And we have yet to do that, testing messages on real people. And so that is an area where we have a tremendous amount of work to do to be sure that this is an equitable rollout of 988, as we've discussed. And then finally, I just want to mention, when you think about crisis services, that is pulling people out of the river. And if we do 988 right, we will pull them out of the river quickly and well and get them back. But what we want to make sure is that we prevent people from going in the river and that they never go in again. And I think we have tremendous work to do to, as Mental Health America likes to say, get before stage 4 and really do that prevention piece. So when we look at the country as a whole, we have to look at, are we ready for the 988 rollout, but are we also ready as a country to embrace prevention and to make sure that people do not return to crisis and live the lives that they want to live?
Thank you so much, Mary, for that input. That was a fantastic overview. I want to go ahead and jump to Wendy now. To prepare states for 988 implementation, Wendy, our report is recommending that CMS and SAMHSA issue joint guidance to state Medicaid agencies and departments of health to help states identify opportunities to coordinate federal funding streams to ensure financing is available across the continuum of care. As Mary just alluded to, it's so important to ensure an equitable rollout. You have been such a leader in standing up Georgia's crisis line and innovatively using Medicaid funding. Can you give our audience today a sense of the current role of state Medicaid agencies in crisis response and how such joint guidance from CMS and SAMHSA will help states?
Absolutely. Thank you for the question. So in my role in Georgia, I'm with the Behavioral Health and Developmental Disabilities Authority, but my primary role is to serve as a liaison to the Medicaid agency. And that doesn't even happen in every state. So it's my business all day long to think about behavioral health and developmental disability supports and services through a Medicaid lens. And so with the years I've been doing that, then that gives me like a real unique lens on the challenges. And the thing that I really am excited about is HHS's commitment in this moment to have been pulling together the behavioral health coalition and collaboration that's happening now between federal agencies specific to behavioral health challenges. This has not always happened. And so what is and will be helpful in the future too is states emulating that and pulling together and having real collaboration and real understanding about what is needed by the citizens of the country and how to take the frame of Medicaid and use it in the most flexible way that's allowed to build the best system for those unique communities. And Congress gave us an amazing opportunity with the enabling of 988, right? That was kind of action, call to action to all of us who are so passionate about this work and about doing it in the right way. But each of us is going to have to think about how this is culturally contexted in our local communities, in our states. What are the tools that we have that are going to rise up to meet the level of need related to 988? And then the ways we frame that in our Medicaid funding mechanisms that's imperative, but we also need to do so with the real expertise of behavioral health leaders who understand what it is like to deliver a service like mobile crisis in a local school, in a local community, on a local street, with the local law enforcement entities if we do co-responder work. So how come down to the local Medicaid agencies and the behavioral health agencies in states really working in collaboration to figure out those dialogue. And then we all know then the Medicaid agency has to go to CMS to have those conversations. We are so glad that SAMHSA and CMS are having these robust conversations to create that space for collaboration that can happen at the federal level that will enable then the states, behavioral health authorities and Medicaid authorities to really do that rigorous partnership together to frame things in the way that the local state citizens need to create access, to engage, not just in the call center work, but in mobile crisis and crisis stabilization. And as Mary indicated, in outpatient mid-range intervention. Mary, you used early intervention, which is crucial, prevention, which is crucial, but many people really, if you can get some good supports, good recovery, services from like certified peer specialists, you can do so much to prevent that crisis. And so we also are going to have to be working on what are the outpatient models that can really catch and receive post these crises incidents and to prevent these crisis incidents. So I look forward and I'm just feeling so positive about what we're seeing coming out of HHS and those partnerships right now. So thank you, Deputy Secretary Palm, who was on here earlier.
Thank you, Wendy. Before I jump to karis, Wendy, I know you just brought up peer support specialists, and I want to ask you and karis both about their role. We did receive a question from the audience, and I'm not sure how easy this question will be to answer, but what would you recommend as some simple information for helping states get started? Because Georgia has been such a leader here, where did you start? Again, I know that's not an easy question to answer, but we'd love your thoughts.
Well, I mean, I feel honored that Georgia did start. And just like 988, the readiness question earlier from Dr. Adams about, the first step and starting, we have to start somewhere. And Georgia took the first step for peer support in 1999. We did so by negotiating with federal CMS that individuals with lived experience are some of the best voices, some of the best champions, some of the best engagement practitioners to work with individuals to instill hope and to reduce stigma and to really introduce the notion of recovery. And so that began with the first step, a conversation with CMS that peer support can work. It didn't exist, but let's do this. And that has grown now. It is more than 23 years old now. Next month will be the 23rd birthday. And I was just very honored to be part of the team that created that model and to have negotiated that with CMS. And I believe, and Georgia has taken every opportunity to infuse peer specialists in every aspect of service delivery where that is an appropriate role. And so peer specialists in Georgia, they work in our crisis walk-in centers. They work in our crisis stabilization units that do overnight supports for crisis intervention. They are part of our mobile crisis teams. They are part of our call center response. And we want them everywhere that individuals engage in the system, because they are a beacon of hope sometimes when an individual is having some of his or her darkest times in terms of a crisis. And so Karis, you hear my passion, and you and I know one another. So let me lob this over to you.
Yeah, Karis, thank you so much. Go ahead.
Yeah, so thank you so much, Wendy. And I think for Wendy and I, this is our first time speaking on the same panel together. But I have to say, California was one of the last states, there's one left, to actually pass legislation for certified peer specialists. And we did that. And I would like to just give a big old round of applause, bow down, whatever I need, to Wendy for helping us think about how to do this and using Georgia as a model in order for us to understand how to craft the legislation, how to have conversation and advocate within our Department of Healthcare Services, as well as for peers who are already providing services, just not Medicaid billable services within our state, to have conversations with their local or county behavioral health departments. So I think, we've had some great analogies about catching people in a river and, a family member trying to figure out how to support their young son. This is exactly the work that peers do. There's another analogy of people being a person who's down in this hole and they can't figure their way out. And everybody's looking down in the hole, trying to tell him, do this, do that, do the other. And a person crawls down in the hole. And the person in the hole says, well, wait, what are you doing in the hole? Now both of us are down here. We're not going to get out. And the person who crawls in the hole says, no, we are going to get out because I've been down here before and I know the way out and I'm going to help you out. And that's really kind of the essence of what a peer supporter is. We've been in this situation before. We've experienced crisis throughout various parts of our recovery journey. So it's a lot easier. We call it rapid engagement for folks who've had that lived experience to be able to engage and partner with others to help them navigate really kind of interesting systems. It's not one system. So to connect to natural supports. And the evidence actually shows how effective a peer support are, especially for people in crisis. Reducing hospitalization and high cost ER visits, connecting people to housing and other supports, decreasing stigma, as Wendy said, for families and parent peer support, increasing confidence in being able to help their loved ones, feeling less alone, feeling less stigma and shame, et cetera. The other thing I think is important is that peer support helps people, because we hear, oh, peer support helps people stay in treatment. And I think the best way to articulate this is that what peer support does is help people feel empowered. So we talk about people, place, purpose. I also want to add another P, which is power, which is autonomy and empowerment, that they feel empowered to be in treatment because they're able to engage in shared decision-making, help people, especially providers, understand what their needs are, and also connect to natural supports that are in the community. So, yeah.
Thank
Do you want me to
Karen.
answer more about Medicaid and Medicaid's role?
I do have another question for you on peer support. I will tee it up for you. One of the recommendations in our report is that CMS issue updated guidance on Medicaid coverage for peer support specialists, which, as some people might know, has not been updated since 2007. In addition to that, you spoke about the important role of peer support specialists across the continuum, and this is part of the reason why we also are recommending a demonstration program for peer respites. Now, in light of 988 and the creation of these continuums of care all over the country, what information from CMS on peer support specialists and how they operate do you think would be the most helpful for states to have?
Sure. So I think one of the things is, so peer respite, definitely, and doing some evidence around the effectiveness of peer respite as part of the array within a crisis system, if you will, I think would be really incredible. Also, I think, what would be helpful is, and this is one of the sticking points we had in California, is understanding what was meant by the criteria of having a high school diploma and/or equivalency. So many people can interpret this as a GED, very literal term of equivalency. That's not quite what it says. And if you look at some of the other states, for example, they have different ways of assessing equivalency of a high school diploma, which is not a GED. So I think there needs to be some clarity there, especially as we understand many people who have mental health conditions that can occur during their education time. It can occur in high school, it can occur at the beginning of college. So many people may not have a high school diploma, but have the ability, skills, knowledge, especially with training, to be able to provide peer support, to be able to do the documentation, and so forth. So I think having some clarity from CMS about that criteria role is going to be incredibly, incredibly important. I also think understanding and clarity around setting rates and how they turn into actual livable wage. Rates and wage are different, but rates impact wage, right? So I think if CMS could provide some guidance around rate setting and alignment with livable wage for peers would also be incredibly important. What services can be reimbursed by Medicaid or Medicare for peer support services, especially related to mobile crisis, mobile teams, outreach and engagement? So we think of all of this happening within some sort of setting that has something to do with the system. Sometimes peers are also doing outreach and engagement, not on a mobile team, and supporting people. How does that get reimbursed by Medicaid? So I think being able to add clarity around the services and supports across the continuum, which also includes those services and supports within Medicaid. Lastly, the supervision. Again, that can become a sticky thing for some states, and understanding how to define who the supervisor is, and can be literally interpreted as the qualified mental health professional or behavioral health professional. People may not look into what does that actually mean within the state guidance. Some people just automatically think, oh, that's a licensed professional. And many times that's not exactly what it means. So I think, getting guidance to the states to understand that people with lived experience who have been in peer roles or recovery coaching roles can indeed be supervisors, as long as it's clarified in the state and the Medicaid waiver, I believe. But there needs to be guidance from CMS to help states look into that versus just making an assumption and moving forward. I think that's what I think those are the few things that I would think of. Maybe Wendy or Mary have others.
Yeah, and I was actually going to jump over to Wendy, because one of the things that we kept hearing throughout the development of our report was that states need clear federal implementation guidance, not just from CMS, but from HHS more broadly. That is why one of our recommendations is that HHS provide more of this technical assistance. Now, we noted earlier that some states are more prepared for 988 than others. Wendy and Mary, what else do you think the federal government can do to help prepare states? For example, what technical assistance do you wish you had had, Wendy, when you were creating Georgia's crisis response line?
The one thing that I will just go ahead and add, because I'm also looking at our time, so I want to be succinct, is that each state generally negotiates and navigates the conversations with CMS kind of one at a time. And then there's this element of then rolling and evolving learning that happens. And I think for this particular initiative, just actioning this on hyperdrive, like how can a state negotiate something and then that information be disseminated and deployed in a rapid cycle approach? It is the one thing when I think about like a federal interchange with state Medicaid and behavioral health authorities on this body of work. How do we have this type of really connected engagement in a fast and efficient manner so that we're all figuring out the answers and moving fast? Because then we have to navigate, negotiate with our legislatures, with our Medicaid leaders, with our governor's offices, to be sure that we're going to pick up that body of work and do it the right way for our unique geographic locations. The one thing I wish I had in terms of technical assistance early on is I would just say it's more of a leadership piece of advice that I would add, is that there was a need for kind of rapid cycle process improvement. So it's got to be a leadership lens of rapid learning and discerning, right? So, I mean, you roll out something and you're going to have to assess it and change and modify as quickly as possible to then be doing the right thing for the individuals who are trying to access service. And so, I'll speak to that. And then the second thing is, again, it's not necessarily a TA item, although I think hearty dialogue about this is necessary, is about the connection point. So 988 is kind of like a call response functionality, but these systems that we spoke to that are enabled in the law, mobile crisis stabilization, these walk-in centers, the potential of peer respite, right? There's so many supporting services that are singular, and we have to create a braid. And so really state authorities are in a really unique role right now to be kind of the space where accountability will happen. How does communication happen between the call centers and emergency departments? How do you manage bed capacity? How do you route folks into the right directions for this post-call intervention when it will be necessary? How do you deploy mobile crisis? Using apps, using different deployment methodologies, and then closing those loops. Those things really are where the state authorities are having to do a tremendous amount of work to build. And like when we rolled out the crisis and access line in 2006, it wasn't, is the crisis and access line working? It's how is it integrating into the system? That's where the sweat equity had to come. Are our providers responding? Are they acclimating? Are they accommodating? Are they creating the access necessary? Is the communication happening? Do you have technical connections between these resources? So really, for me, like that is kind of where the real work for success is going to need to come. So Mary, do you want to chime in on any of that?
Well, I'll just add that as you look at the braiding of the funding, two big funding sources that we haven't had a lot of time to discuss are Medicare and private insurance. So Medicare does not do a particularly good job financing crisis services, does not cover peer services. And there are some proposals to change that, particularly in integrated settings. And then private insurance often does not cover crisis care. As 988 rolls out, we fully expect that more people with private insurance will know about it and call, and they should be doing their fair share. So there are some recommendations in the report around a parity analysis and more guidance on emergency services and how crisis fits into that, so that private insurance does its fair share. Because if we're saying this is a health response to a health crisis, then health insurers need to pay.
Thank you so much, Mary. I was actually going to ask you a question on parity, but seeing that we're short on time, and you answered the question, thank you. I want to drill down kind of to what Wendy was talking about when we look at what states need. One of our recommendations is that SAMHSA should encourage states to implement 988 utilizing a standard set of performance-based indicators in the form of a scorecard. We think this will allow states to compare progress among states and over time, and perhaps highlight areas where states need more support. In which ways do you think that the federal government, if the scorecard was implemented, would be able to use it to support those states that need help?
Yeah, I think it's a very important recommendation. We've discussed on this call all the gaps, and the way you know where you're going, you have to have some kind of way to analyze that, to look at it and plan out a roadmap. So I think that is very, very important. As SAMHSA looks at what those indicators will be over time, I also just want to point out two things. One is that patient experience matters. Mental health services at times have been traumatizing to people and sometimes even dehumanizing. So we've got to gather that data on what is the experience in a standardized way by demographics, going to the discussion about equity. So a scorecard is very important, as is measuring the experience of people who are receiving these services. If we're going to realize this vision, we have to do it for everyone.
And the one thing I'll just chime in as a state authority, right, is that states are in a different place. We're all starting. The first step is going to be a slightly different size leap as we are moving into this amazing journey together. And so just also being sure that folks are mindful of when we set those performance expectations, understanding sometimes how challenging launching some of this content is. If you're building a crisis stabilization program, you don't just pop one up. The funding doesn't happen and you just don't build it. You're talking about an 18-month-ish process to get the doors open. So really having this kind of accountability measurement that is flexible based on where states are too, while pressing and pushing and encouraging is going to really be necessary.
Thank you, Wendy, and thank you, Mary and Karis, to all three of you for helping educate our audience today. I know we had more questions. I'm sure there's more from the audience that we just can't get to, but we hope you all will take a look at our report because we think it addresses really well some of these challenges. To close out, I want to say thank you again to all of our speakers, Deputy Secretary Palm, Dr. Adams, Dr. Everett, again, Mary, Karis, and Wendy. Thank you to all of you for joining us today. Thank you as well to Anand for helping me to moderate today's discussion, as well as to the entire BPC team who worked on this report. And thank you, last but not least, to our audience for tuning in. We welcome any opportunity to work with you all on this report, as well as on previous and possible future work in behavioral health or in the healthcare space generally. Please feel free to reach out to us. And thank you so much for tuning in.